Hey, welcome back. Let's go ahead and dive into metastatic HER2 positive disease. Now, remember, when we say metastatic HER2 positive, what we're suggesting is that there is a primary in the breast that is HER2 positive, or there is a lesion, again, bone, liver, or the lung that is HER2 positive. And IHC immunohistochemistry determines 1 plus, 2 plus, or 3 plus in terms of expression of the HER2 protein on the cell surface. If it's 3 plus, it's definitely HER2 positive. If it's 1 plus, we might say that's HER2 low or negative. And then if it's 2 plus, this is equivocal. And then what we should do is something called the fluorescence in situ hybridization to verify whether or not it is HER2 positive or HER2 negative, right? Keep in mind too, the primary could have been addressed years ago. The patient could have underwent adjuvant or neoadjuvant treatment, then surgery, and then adjuvant treatment and had a remission. And this new lesion that has been detected in the bone, the liver, or the lung could be then a recurrence of the disease at a metastatic site. Okay, so that's our framework for metastatic HER2 positive disease. And when you do have a recurrence at a distant site, again, we have to verify that it is HER2 positive because that predicts how we're going to go and treat the patient. Sometimes our HER2 positivity is also met with hormone receptor positivity. And when you have HER2 positive and hormone receptor positive disease, the pace of the disease and how severe the disease is going to essentially predict or inform you how to go about treatment. If the patient has a rapidly progressing lesion that is symptomatic, you're going to go ahead and proceed with HER2-directed therapy in combination with chemotherapy, right? If that patient has sort of more of an indolent disease, where there's a little bit of HER2 positivity and some hormone receptor positivity, but they're not progressing that quickly. It's somewhat indolent. Maybe you opt for HER2-directed therapy in combination with endocrine therapy. Okay. Now, let's focus in on this section, though. And we'll make mention of the endocrine therapy as well. If it's hormone receptor positive and HER2 positive, we can go ahead and use HER2-directed therapy in combination with some form of endocrine therapy. And again, too, this is going to be in those patients that don't have very, very rapidly progressing disease that are symptomatic. Okay. And we do need to consider the menopausal status because that can help predict then what type of endocrine therapy to use. Ideally, though, your patient is going to have their ovaries suppressed. They'll be in a state of, post-menopause, which is going to allow you then to use an aromatase inhibitor. Then you're going to combine that aromatase inhibitor with some form of HER2 inhibition. We could use trastuzumab plus an aromatase inhibitor, right? Or you could use a molecule again that I mentioned last time, lapatinib, plus an aromatase inhibitor like letrozole. Right? Both of these are oral agents. They both together increase progression-free survival. There are some toxicities associated with that, however. If your patient ends up being premenopausal, you want to basically induce a state of postmenopause or menopause in that patient. You want to make them postmenopausal, and then you go ahead and treat them as such here. And again, to these particular recommendations, the AI plus trastuzumab or the AI plus lapatinib, right? These are options. These are options for indolent disease. What do we do though when our patient is unfortunately not having indolent disease, when they have HER2 positivity with rapidly progressing disease? That's when we're going to use HER2-directed therapy in combination with chemotherapy. And I can promise you this is going to be on the exam, and you're going to get asked this as well. The treatment of choice, the mainstay of treatment today for the initial treatment of a patient with HER2-positive metastatic breast, that's trastuzumab naive, is going to be a taxane, docetaxel, plus trastuzumab plus pertuzumab. Right? Those three agents combined together make for the category 1 recommendation for HER2 positive stage 4 disease. Okay, pertuzumab added to that combination improves survival outcomes. If your patient did have some prior exposure to trastuzumab, we need to ask ourselves, how long has it been since the last dose of trastuzumab? And is this recurrence that we're dealing with? Is this a recurrence of the primary, or is this progression of metastatic disease? So by way of example, if your patient got trastuzumab in the adjuvant setting and it has been longer than 6 months since the last dose of trastuzumab, that suggests that they had a response, a durable response. And if they present today then with metastatic disease, we can start them on the taxane plus both trastuzumab and pertuzumab. If your patient has metastatic disease and they're progressing on trastuzumab therapy, what's really recommended at this point in the second line is this guy, and HER2, trastuzumab deruxtecan. That's the antibody drug conjugate that has shown wonderful results. Trastuzumab deruxtecan has displaced trastuzumab and tansine, as the preferred second-line agent because of how good patients respond to it. Let's look at this frame very quickly. First line, I need you to know this. HER2 positive metastatic disease. First line, pertuzumab plus trastuzumab plus docetaxel. Category 1 preferred. Know this. You will be asked, what is the preferred therapy? You'll type that out. You could use pertuzumab and trastuzumab plus paclitaxel as well. It is still a preferred first-line agent. The caveat here is that the use of docetaxel is backed up by more clinical data, more studies. In the second line, trastuzumab deruxtecan. Right? When your patient progresses on pertuzumab, trastuzumab, and paclitaxel or docetaxel, we can go to trastuzumab deruxtecan, and the Destiny breast trials have proven this drug to be very, very useful. We may hear about third-line agents. There is a combination called tucatinib, trastuzumab, and capecitabine. The HER2 CLIMB study proved that tucatinib was beneficial, in particular in treating patients with CNS metastatic disease. But that's for a later time. I need you guys to focus in on this one and this one for sure. Okay. All right. This summarizes things for stage 4 disease for HER2 positive. So you'll know this and know this and know this. Review that for us. And then this last slide, we'll come back to this because this opens up a whole can of options depending on the various biomarker being investigated and the driver of the disease. Right? So we'll spend a little bit of time talking about this when we come back. Thank you.